Everyone, and thank you for joining. My name is Cleary, and I'm joined this evening by Sarah Singh from the Middlesex London, Ontario Health Team, and Dr. Devon Shewfelt, a family physician and executive member of the Middlesex London Primary Care Network. This is the third and final episode of our series on the interdisciplinary primary care team expansion proposal, and tonight we'll be discussing the geographic analysis for the Middlesex London, Ontario Health Team region. I'm going to bring that over to Sarah to bring you through it.
Thank you, Connor. Hi, everyone. My name is Sarah. I'm the Quality and Analytics Coordinator for the Middlesex London, Ontario Health Team. And today I'll be taking you through the geographic analysis. What is the geographic analysis? The geographic analysis integrates data from multiple sources to support primary care planning, including access and attachment to a primary care provider for every member of our attributed population. The analysis has been performed using an online platform tool named the Primary Care Map, which is a collaboration between the Middlesex London OHT and Western geographer Dr. Jason Gilliland. The analysis helps us to understand areas of priority based on social determinants of health and rates of unattachment. Estimates show that the Middlesex London region now includes over 94,000 individuals that are unattached to primary care. The waitlist is approximately 13,000 individuals, with 600 of those individuals being listed as complex vulnerable. A further breakdown of numbers shows higher unattachment rates in some regions as opposed to others. However, it is important to note that unattachment affects the entire Middlesex London region, and we need everyone involved to tackle this problem. The prioritization criteria for the geographic analysis are as follows: accessibility and supply, proximity to primary care and primary care services, unattachment, including the number and proportion of unattached, and social determinants of health, including marginalization, age, income, Indigenous, and the Francophone population. The Middlesex London region attributed population exceeds 600,000 individuals and spans a large geographic area shown in yellow on the map. Looking closely at accessibility and supply, we can see that the Middlesex London urban centre contains the majority of physicians, while the rural areas sees a scarce supply. Similarly, for primary care services, the majority of services are centered in the Middlesex London region, and there are less services in the surrounding rural regions. When looking at unattachment, we can see that higher unattachment are shown in areas of brown and dark orange. Higher unattachment rates exist within the London urban centre as compared to the surrounding rural areas. Social determinants of health, such as low income, can also be mapped and is shown to be diverse across the entire Middlesex London region, with areas within the London urban centre and towards Huron Perth showing low income. We're embracing a community health home hub and spoke model that was referred to and further explained in episode 2 of this series. Let's look at a few geographic areas that can be potential urban hubs and spokes. The first region that pops up is East London. The exact region is shown in grey on the map. The total population exceeds 12,000, the total unattached population exceeds 3,000, and the marginalization in this area is high. There are existing partners. One perfect example is the London Intercommunity Health Centre. This is an existing team that resides in this region and can provide primary care. Another example is the West London district. Population here exceeds 16,000, and the total unattached estimates almost 4,000. And the marginalization is again high, and existing primary care includes the Thames Valley FIT, the London FIT, and various foes. Another key area of need is central London. The population here exceeds 11,000, with the total unattached almost reaching 3,000. The marginalization is again high, and the existing primary care is the Thames Valley FIT, the London Intercommunity Health Centre, SOHAC, and various foes. Finally, the region towards the south end of London, Glanworth, Brockley, Temple, Sharon Creek, consists of over 24,000 individuals, with over 4,000 being unattached. The marginalization is mid to low. However, there are no known primary care teams existing in this region. Looking now at the rural areas slightly outside of the London city centre. Rural west of London contains an area with over 9,000 individuals, and over 1,000 of those individuals classified as unattached. The marginalization is mid to low, and existing primary care includes the Southwest Middlesex Health Centre and SOHAC. One of our final regions is rural east of London. The population here amounts to almost 14,000, with almost 1,000 of those individuals being unattached. Marginalization is mid to low, but there are no known teams in these areas. These areas are only a snapshot of possible areas within London where primary care teams are needed for greater attachment. I'll pass you on to Dr. Shewfelt.
Thanks so much, Sarah. And thanks again to everybody for your time and attention at whatever time of day and place you're giving us that. Now, geographic analysis is the first step in really understanding the population's health, and we're using this data to plan a system that meets the needs of our community. Understanding this information is relevant to us as primary care physicians and nurse practitioners for a number of reasons. Geographic analysis is ongoing, and data is updated regularly. This allows for current information about the communities around you. It in turn gives you the information you need to request specific supports to meet the needs of the community. Having access to up-to-date data in our communities can give us the ability to understand those that we serve. This is a call to action. We need your support. You don't have to be in that community to help that community. Would you be able to serve more patients if you had access to additional supports, such as intake support, an interdisciplinary team, or referral and system navigation resources? Your participation is very important, and we need as many providers as possible to participate, regardless of where or how you practice. We still want you to be a part of this work. We will all need to work together to build a system that will attach everyone on an ongoing basis, provide timely access, and we all want to work in. Please email hello@mlpcn.ca to get involved. We'll be hosting collaborative proposal development sessions for all those who indicate they're interested in being a part of the proposal. We'll share dates and times later this week. Thank you again so much.
Everyone for joining.